Have you ever rushed a patient for ST elevation and the coronaries were completely normal? Well, that's the difference between diagnosis and pattern. ST elevation on ECG does not automatically mean STEMI, while acute coronary occlusion is the most dangerous cause and must always be ruled out urgently. Several non-ischemic and non-occlusive causes can also produce ST elevation. The key is understanding the morphology, distribution, and clinical context. In acute STEMI, ST elevation is typically localized to a coronary territory, often convex or straight in morphology, and associated with reciprocal ST depressions in opposite leads. Patients usually present with ischemic chest pain and evolving cardiac biomarkers. This reflects transmural myocardial injury due to acute plaque rupture and coronary artery occlusion. However, pericarditis can produce diffuse ST elevations across multiple leads, usually concave upward, often accompanied by PR depression. Unlike STEMI, there are no true reciprocal changes except possibly in AVR, and the pain is often positional or pleuritic. Early repolarization, commonly seen in young, healthy individuals, produces stable concave ST elevation, most prominent in precordial leads, often with J-point notching or slurring and no dynamic changes over time. Left ventricular hypertrophy can also mimic ischemia. In LVH, ST elevation may appear in leads with deep S wave due to repolarization abnormalities, often accompanied by strain patterns. Brugada syndrome produces ST elevation in V1 to V3 with a characteristic curved or saddleback pattern and carries a risk of sudden cardiac death, but it is not caused by coronary occlusion. Hyperkalemia, especially in severe cases, can widen the QRS and distort ST segments, further mimicking ischemic changes. The critical principle is this: ST elevation is a pattern, not a diagnosis. The ECG must always be interpreted in the context of symptoms, serial changes, biomarkers, and risk factors. Immediate reperfusion therapy is life-saving in true STEMI, but inappropriate activation of the cath lab for non-occlusive causes can expose patients to unnecessary risks. In cardiology, the skill is not recognizing ST elevation, it is recognizing which ST elevation matters.